Thank you very much for the kind introduction, and sorry for being late. It's really a pleasure for me to be here. And in the next 25 minutes, I will try to discuss some selected abstracts related to CAR T-cell lymphomas that were presented, the CAR T-cells in patients with lymphomas that were presented at the last EBMT meeting. So here you have my conflicts of interest. And here you have the 4 different points that I'm going to touch in the agenda for the next minutes. So a little bit on some follow-up analysis on CAR T-cells as third line or plus in patients with relapsed refractory aggressive B-cell lymphomas. What about moving CAR T-cells in second-line therapy, academic CAR T-cell constructs, and predicting response to CAR T? So as you know, we have been using for the last few years these 3 different autologous CD19 constructs that have been basically approved by the FDA and the EMA to treat patients with relapsed refractory aggressive B-cell lymphomas. You know that we have 3 different phase 2 pivotal trials that gave the indication to these 3 different products, and we had updates in EBMT regarding Lysocell with the pivotal trial, which is the Transcend trial, which you have here depicted in this slide. So this trial, which is a phase 2 prospective clinical trial, included adult patients with relapsed refractory large B-cell lymphoma that were treated with Lysocell, with this type of lymphodepletion therapy that you can see here in this slide. The primary endpoint was overall response rate, and bridging therapy was allowed. 270 patients were included here with a median age of 63 years. More than 50% of the patients were diffuse large B-cell lymphoma. We have a small proportion of secondary CNS lymphoma. We have more than 60% of the patients that were chemorefractory to prior lines of therapy, and more than 50% of the patients received bridging therapy before CAR T-cell infusion. With a median follow-up of 24 months, as you can see here, the median duration of response for the global population of patients was 23.1 months, which was higher in those patients that achieved a complete remission, and it was significantly lower in those patients that only achieved a partial remission with Lysocell. The overall response rate was 73%, and the complete remission rate was 53%. Progression-free survival, the median progression-free survival for the global population of patients was 6.8 months, being 27.3 months in those patients that achieved a complete remission, and only 2.8 months in those patients in partial remission. And here you have the data coming from the overall survival with a median follow-up of 29.3 months. The median OS was 27.3 months in the global population of patients, then went up to 48.5 months in those patients that achieve a complete remission, being 9.0 months in those patients that achieved partial remission only. I'm bringing this slide here regarding the adverse events of special interest because, as you know, Lysocell is probably the best tolerated autologous CD19 CAR T-cell construct that we have nowadays, better than Axi-cell and better than Tisa-cell. And we have only 6 patients, 2% of the series, that developed grade 3 to 4 CRS, and we have 10% of the patients that developed grade 3 to 4 neurological events. The other pivotal trial that was updated in this last EBMT meeting was the ZUMA-1 trial that gave the indication to axicabtagene for patients with relapsed refractory aggressive B-cell lymphoma that failed at least 2 prior lines of treatment. I'm not going to present the follow-up of this trial, but I would like to present you the follow-up of cohort number 6, which was a group of 40 patients with relapsed refractory large B-cell lymphoma in where tocilizumab on corticosteroids were included earlier on in the treatment of adverse events of special interest to try to decrease as much as possible the toxicity associated to Axi-cell. So here you have the adverse events management in ZUMA-1. In the upper part of the slide, you can see the potential use of tocilizumab and corticosteroids, depending on the grading of both CRS and neurological events. And as you can see, in cohorts 1 and 2, tocilizumab and corticosteroids were not allowed to be used in grade 1 CRS and neurological events, and corticosteroids were not allowed to be used in grade 2 neurological events. And here you have the pattern of use of both tocilizumab and corticosteroids for patients included in cohort 6, where tocilizumab was not allowed to be used in grade 1 neurological events, but then there was a more flexible use of tocilizumab and corticosteroids in the other grades. So basically, the median follow-up of the different cohorts was a little bit higher than 1 year, and a propensity score match comparisons were performed to compare clinical safety, efficacy, and PK profiles of patients included in cohort 6 versus patients included in cohort 1 and 2. If we look at the primary endpoint of this cohort number 6, and we have a look at the incidence and severity of CRS and neurological events, we have to highlight that there were no grade 3 or plus CRS occurring in patients included in cohort 6, and grade 3 or plus neurological events were reported in 15% of the patients. What about efficacy? As you can see in this slide, the median duration of response, progression-free survival, and overall survival were not reached in these 40 patients included in cohort 6, and the Kaplan-Meier estimates of the 12 months duration of response, PFS, and overall survival were 60%, 63%, and 82% respectively. If we look at the outcomes here in terms of efficacy, this propensity score comparison, you can see that clinical efficacy remained comparable between patients in cohort 6 and cohorts 1 and 2 before and after the propensity score-based matching, with an objective response rate which was higher than 90% in both groups of patients, a complete remission rate which was higher than 75% in both groups of patients. If we look at safety, after the propensity score comparison, the incidence of grade 3 or plus CRS was lower in cohort 6 in comparison to cohort 1 plus 2. The median time to onset of any grade of CRS was somewhat delayed in cohort 6 in relation to cohort 1 and 2, and in the same way, the median time to onset of grade 3 or plus neurological events also appeared to be delayed in patients in cohort 6 with respect to cohort 1 and 2. So let's go to the second topic of the agenda. So what about moving CAR T cells into second-line treatment? You know that there were 3 prospective clinical trials that were presented at the last ASH meeting, and 2 of them were also presented in the last EBMT 2022 meeting. In this slide, you have the design of ZUMA-7, which was one of the 2 positive trials that has already given the indication of axicabtagene in second-line therapy approved by the FDA only a few weeks ago. This is a phase 3 prospective randomized clinical trial where patients with primary refractory disease and patients with early relapse were randomized 1-to-1 to receive axi-cel, 180 patients, or a standard of care, 179 patients. No bridging therapy was allowed in this trial, and no crossover strategies of patients being included in the standard of care being switched to axi-cel treatment was allowed. The primary endpoint was event-free survival evaluated by a blinded central review. So the first thing I want to mention is that while more than 90% of the patients that were allocated to the axi-cel arm actually received the infusion of CAR T, only 36% of the patients that were allocated to the standard of care, so high salvage chemotherapy and high-dose chemotherapy with autologous stem cell transplantation, actually received the autologous stem cell transplant. Here you have the clinical characteristics of the patients included in this study. They were well balanced between both groups of patients. I want to highlight that 30% of the patients were older than 65 years of age. We have more than 70% of the patients that were primary refractory, and an interesting proportion of double expressors and patients with MYC rearrangements. Primary endpoint favored the experimental arm, so the trial was positive. 2 years event-free survival for patients being treated with CAR-T was 40% versus 16% for those patients that were treated with the standard of care, and the median follow-up is 24 months. As you can see in this slide, also the overall response rate and complete remission rate were significantly higher for those patients being treated with AXI, 83% versus 50%, and 65% versus 32% respectively. And although there are no significant differences, at least for the time being, in terms of overall survival, you can see that the blue curve goes a little bit higher than the red one or the pink one. And we have to take into consideration that more than 50% of the patients in the standard of care arm that failed or relapsed, they were able to receive off-protocol subsequent cellular immunotherapy. In addition to that, if we look at patient-reported outcomes with the different type of measures that were used in the trial, so there is a benefit for AXI in front of the standard of care in both days 100 and eventually day 150. Also, what we were able to see in this last EBMT meeting was a pre-specified subgroup analysis that was specifically looking at the results of axicabtagene versus the standard of care in the elderly population of patients that were included in ZUMA-7. And here we are taking into consideration 109 patients, 51 randomized to the axi-cel arm, 58 randomized to the standard of care arm. And as you can see, as we have seen in the intention to treat population, 96% of the patients at the end of the day received the axi-cel, while only 34% of the patients received autologous stem cell transplantation in those that were randomized to the standard of care arm. Once more, and here the differences are even more striking. Of course, we cannot compare anything. With a median follow-up of 24 months, the event-free survival was significantly better in the axi-cel group, 47.8% at 24 months versus 15.1% in those patients that were consolidated with an autologous stem cell transplantation. And as expected, we have similar figures to the ones that we have seen before with respect to the overall response rate, 88% versus 52%, and the complete remission rate, 75% versus 33%. And non-significant, but somewhat better results also in terms of overall survival, favoring those patients that had been treated with CAR-T. So the second phase 3 prospective clinical trial that was also presented in the Presidential Symposium of the EBMT 2022 was the TRANSFORM trial that compares face-to-face lisocabtagene with the standard of care in a group of early relapses and primary refractory adult patients with aggressive non-Hodgkin lymphoma. Randomization was also 1-to-1. Here, bridging therapy was allowed, and also crossover to liso-cel was allowed in those patients being included in the standard of care arm. And the primary endpoint was also event-free survival. So here I want to mention the same concept that I have mentioned for ZUMA-7. So 84.7% of the patients randomized to the liso-cel group actually received the CAR-T cell infusion, while only 34.7% of the patients that were randomized to the standard of care arm received an autologous stem cell transplant. Here you have the clinical characteristics of patients included in both groups. So we have a slightly higher proportion of males than females. Median age is around 60 years. The most frequent histological subtype was diffuse large B-cell lymphoma, NOS. We have also more than 70% of the patients that were included here because of primary refractory disease. So there were significant differences, basically in terms of complete remission, 66% versus 39%, favoring patients included in the lysocell arm, and also the overall response rate was favoring patients being included in the experimental arm. And this was translated into a significant benefit in terms of event-free survival, which was the primary endpoint for those patients that were treated with lysocell, with a median EFS of 10.1 months versus 2.3 months in those patients being treated with the standard of care. Although we have to recognize that here the median follow-up is significantly shorter, only 6.2 months. And that was translated into a non-significant, but what maybe might be a potential significant benefit in the future in terms of overall survival for those patients that were treated with lysocell. So I'm going to go to the third point of the agenda, and I'm going to present you an oral communication that was given in the last EBMT meeting, looking at academic CAR-T, and maybe this is one thing that we might discuss later on. So that's a presentation coming from the, have to go backwards, coming from the Heidelberg group using a third-generation CD19 CAR-T. It's an academic trial that was basically looking at patients with adult acute lymphoblastic leukemia, CLL, and non-Hodgkin's lymphoma. The trial was initiated in September 2018, and preliminary results were presented at the last EBMT meeting. 38 patients were screened. There were 2 screening failures. 36 patients were enrolled, leukapheresed, manufactured. 32 patients already received at the time of this presentation the CD19 CAR T-cell product, and we have 28 patients that were evaluable for the end of the study, which was on day plus 90 after CAR T-cell infusion. As I have said you before, 2 different subgroups of patients were included in the trial, adult ALL, although there is the objective to include pediatric ALLs too in the near future. And then stratum 2 was constituted by non-Hodgkin lymphoma plus CLL. You have already seen this information. As expected in a phase 1 prospective clinical trial, there were different dose levels from 1 times 10 to the 6 CAR T cells per square meter to 20 times 10 to the 6 CAR T cells per square meter, with a small proportion of patients included in the 2 different stratus and with different dose levels that are basically planned for the future, and also, as I have said before, including a group of pediatric ALLs. So what about responses? 13 patients with ALL were included in this presentation with an overall response rate of 84% and 54% of the patients achieving a minimal residual disease negative complete remission. With respect to the 18 patients that were included because of non-Hodgkin lymphoma and CLL, the overall response rate was 50%, with 44% of the patients achieving a complete remission. The tolerability of this construct was really very good. As you can see here, high-grade CRS was presented only by 3% of the patients. There were no ICANS of any grade, and there was a declining over time hematological toxicity, as you can see here in this slide. Here you have the progression-free survival and the overall survival curves at day plus 90 after CAR T-cell infusion, which are really promising, taking into consideration the adverse group of patients that were included in this study. And here you have the overall survival curves and the progression-free survival curves with a median follow-up, which is around 1 year. Of course, at least for the time being, there is no plateau for either patients being included because of an ALL or patients with non-Hodgkin lymphoma and CLL. Interestingly, there was PFS dose-dependent fashion, and as you can see here, higher doses were associated with better results in terms of progression-free survival for both patients with ALL and patients with non-Hodgkin lymphoma and CLL, although we have to admit that the follow-up is really very short, and of course the number of patients included in this study is also quite small. And finally, I want to present you also this oral presentation that comes from a single institution in Milan, looking at the potential capacity of early expansion kinetics to predict disease response and survival after CAR T-cell infusion. So that's a prospective observational study on patients with aggressive lymphoma that were treated with commercial Tisacel or Axicel at the Istituto Nazionale dei Tumori in Milano, Italy. And they enrolled consecutive patients at the time of leukapheresis from December 2019 to October 2021. Here you have the clinical characteristics of the patients that were included, a global number of 53 patients, 27 treated with Axi, 26 treated with Tisacel, and there were several differential clinical characteristics, which is between Axi and Tisa, which is something that we have seen in other institutions. So it seems that patients being treated with Tisa, they were slightly older. We have, as expected, more primary mediastinal B-cell lymphomas in the Axi-cell-treated group. Patients in the Tisa group were more heavily pretreated. There was a higher proportion of primary refractory patients, more patients with advanced disease, and with high IPI 3 to 5. And maybe more patients needing bridging chemotherapy. What about the clinical outcomes, in spite of these differences? But of course, this is really a very small study, and of course, it's an observational study, but there was no specific selection. We can see that the overall response rate and complete remission rate on day 90 are quite similar between both constructs, and we can see different patterns in terms of CRS, grade 2 or plus, and ICANS, as can be expected. Here you have the expansion kinetics for Tisa and Axicel with some differences as they have already been demonstrated in the literature. So probably a higher peak for Axicel and then a more prolonged evolution over time for patients with Tisacel. And as you can see in this slide, the maximum expansion was achieved on day 10. And there was a very strong correlation between the area under the curve and the C10 parameters. And in principle, as you will be seeing later on, there was a correlation between these good expanders and complete remission and partial remission by day 90 after CAR T-cell. So on the univariate analysis, the expansion on day 10 was a significant prognostic factor for day 90 response, and that this significance was maintained in the multivariate analysis for day 90 response, as you can see here in this slide. And the response analysis for good expanders by AUC basically showed similar results. Also, expanders by day 10 had a longer progression-free survival. As you can see in this slide, the median progression-free survival was not reached in those patients that had a good expansion, while the median progression-free survival was lower, 3.6 months, in those patients that were poor expanders. So basically, and some comments, of course, it's very difficult to conclude from a highlight presentation. I think that all of us would agree that CAR T-cells give promising long-term results in patients with relapsed refractory large B-cell lymphoma. They are moving really fast into second-line treatment, and eventually we will see them in first-line treatment strategy in patients with high-risk disease. The results in the elderly population of patients are really promising, and I think that that's really important, taking into consideration that for these elderly patients that are primary refractory and have an early relapse, curative options are almost absent, and probably nowadays we have more questions than answers in the setting of CAR T, and we may be discussing about the role of academic CAR T, and of course how to better predict those patients that will fail this treatment strategy. So with this slide, I want to invite you to the next annual EBMT meeting that is going to happen in Paris. Hopefully it's going to be face-to-face if everybody allows us. And thank you very much for your attention. I'm happy to take some questions.